Medical disclaimer. Please note that the information shared on this podcast is for educational and informational purposes only and should not be considered medical advice. Always consult with your healthcare provider before making any changes to your health regimen, including starting new therapies, supplements, or treatments. While we discuss cutting-edge research and advancements in cellular medicine, individual health needs vary and professional guidance is essential. By listening to this podcast, you acknowledge that neither Dr. Seeds nor the podcast team is providing personalized medical recommendations.
On today's episode of Redox Revolution, Dr. Seeds is back. Welcome back to the Redox Revolution, and I am back. Yes, I am back. And thank you for letting me and my faculty get ready for our peptide certification course that it really does, it takes a lot of work to do everything well and do it right. And I can't thank my faculty enough for putting up with me and the time that we put into it. And it was a stellar event. Matt,
you guys crushed it.
You guys, the team, Maddie, it was just incredible. And I actually miss being down there with everybody. It
wow.
was, I know, right?
Oh, who
Mr.
are you?
Social butterfly over here.
We're going to have to ask at some point when we have Leah on, we're going to have to ask her about that social connection type of thing. What's going on with me?
Yeah, what's
Well,
happening?
she'll be here in a few weeks.
Yeah, who are you?
But I'm back, and I'm excited. Let's get this thing rolling, Matt. Where are we going today?
Yeah, this has been a long time coming. By a long time coming, I mean you brought this up right before we went on your certification break. But today we're actually going to talk about a very recent clinical study that came out on GLP-1 receptor agonists. So
well, wait a second. I wrote a book on GLP-1.
Oh, then you're just the guy to ask. This is perfect.
What?
Oh my God!
The stars are aligning for so many things.
What a coincidence!
Is this a new paper? Is this not in the book?
So the article, semaglutide slows epigenetic aging in people with HIV-associated 3 lipohypertrophy, evidence from a randomized controlled trial. It suggests that it's the first clinical trial evidence that semaglutide, quote, modulates validated epigenetic biomarkers of aging. It's preprint, hasn't been peer-reviewed by a journal yet, but yeah, our understanding is you have a thing or two to say about it. So,
Were you aware of this article, or did Matt just find this article?
Oh, yeah, no, I found it. It wasn't him.
I figured you found it because we know you're deep into the beta cell, figuring out what that is. So
That's wow, what a episode 1 callback.
Mm-hmm.
Okay.
Wow,
But,
you
yeah.
guys are taking me back in time. Yeah, I actually, believe it or not, I know about that article.
wow.
Yeah.
Tell us about it.
Yeah. Well, it's where did you get that article?
You.
Oh,
Yeah.
Maybe you got it from me.
Little.
did I get it from you?
I don't know.
I probably did.
I'll take the credit.
I
yeah.
probably I by the way, I get a lot of articles from Maddie, who is always searching. She has these Google searches, these things that just go 24/7, and she's sending me. I don't know if she tries to stump me. I don't know what she's doing, but she sends me nonstop articles, and some of them are really good, and some of them, and you probably did send me this one, because I wouldn't have found it if it was a preprint. That means it was a BioRev. It's not peer reviewed yet, but let's talk about this because actually this is a good paper to, I think, to put some perspective together from what we do in cellular medicine and what's out there for the public and for healthcare providers to utilize in referencing chronological aging and biological aging. And and let me put this together about what this paper is about. Okay, so
And I'll lay the groundwork here and let you get into your thing. So it was a 32-week study, placebo versus control.
thank you for telling me all
And,
this stuff because I don't think I remember.
32. It's so funny how like you don't prep for any of this, and yet you can still talk for like 40 or 50 minutes. It blows my mind. But
Imagine
anyway,
if he did prep.
huh?
Imagine if he did prep.
I feel like it wouldn't be
Woof.
as good.
It'd be terrible.
Yeah. Anyway, it's a 32-week study, placebo versus control, and it was 108 participants who have HIV and were obese. All right, Dr. Seeds, go.
Well, this is a paper. Let's just put it into clinical context, I guess, first. This is a paper on using methylation studies on peripheral blood that's taken, blood samples that are taken from the vein, that they evaluate their immune cells, in particular mononuclear cells, that are where they're looking at the methylation of an immune cell, and then they're speculating based on algorithms aging of different organs. The immune system as a whole, the brain, the heart. So it's like they're trying to extrapolate what happens in an immune cell and say, hey, based on this methylation, this is what's happening also potentially in these other 11 or so, I think the paper referenced 17, or 11 methylation clocks that they look at, organ clocks. But go ahead, you.
Just for the listeners who might not know what methylation is, just the transfer of energy from cell to cell throughout the body. That's all.
Right, and how methylation suppresses it'll suppress some of that activity versus it will open up activity. It's like, I think the easiest thing to think about, that's a great thing to bring this up. You guys hear methylation all the time. Methylation is something that basically controls, let's just say it controls DNA, and how DNA will transcribe or will create a message for a cell to do something, to make a protein, to make an enzyme, it's that messaging. And so if you methylate a certain area of the DNA, or what's called the histone, it can repress that signaling that normally should go on in a cell. So that's really good you brought this up, because
Thank you.
people are probably saying, what the hell is he talking about? So thank you for bringing me back. That's very important. That's the basis of what this paper. So this paper is trying to correlate methylation to longevity.
Ooh, your favorite word.
I know, this is where it gets to me. So let me just say, hey, look, good. It's a paper that has a place of, like they're going to want to say, invalidating that a GLP-1 like semaglutide they're going to say, hey, it's a longevity drug. It's going to improve lifespan because based on these clocks and they use different clocks, PhenoAge and GrimAge, and different type of clocks where it may have shown 5 years, 3 years, 2 years of improvement.
But isn't this what you've technically been saying for the past 12 years, that even though you hate the word longevity, this peptide is that one longevity peptide because of the autophagy effects it has?
Cool. Well, yeah, so let's go. You're jumping ahead and very smart with what you're saying. Let me put this in. This is great that you brought this up, because there's some context that we really can use here. Methylation is, think of methylation as studies or methylation clocks as a way to predict. It's used to predict morbidity and mortality. Mm-hmm. It's not used to predict if you're going to have a a glial cell, an astrocyte in the brain, if you're improving its function to do its job in making lactate for the neuron and improving metabolism, or it's not there to prove that that it's going to improve atherosclerosis in the heart. It's just a morbidity mortality statistic. And this is where I kind of get a little bent on when these companies try to come in and they word things to say, hey, we've got this test, because that's what they're doing here. They're using this to come to physicians and healthcare providers to say, hey, I've got the test that does this methylation, and let's use it on your patients to show what you're doing, that you're improving their age, their longevity, which is total bullshit. And I don't mean that. I think it has its place in research. I think this is but I don't need a damn methylation clock to tell me something where I know the mechanistic biology already has been proven. The studies have already been done. I can already tell you. This is where I'm getting a little upset now. Like,
love it.
I can already tell you, we can go through the molecular pathways of AMPK and how AMPK, we know that GLP-1s improve AMPK. Like, do you want me to go through the mechanistic parts of how this? I can go through the mechanistic pathways of AMPK, mTOR, NFRKB, NFR2, IGF-1, SIRT1, SIRT3. I mean, we can go through all those mechanisms and pathways that we're so passionate about and show you the papers that have been validated to show that you're improving those aspects in the cell. So why do I need a damn methylation test to tell me what I already know is already happened, already been proven? Like if they told me they were going to do this and, hey, we're going to show this study, I'm going to say, well, I'm going to tell you that, yeah, you're going to improve that age thing you're all worried about. But does longevity mean you're going to improve? If I know mechanistically, like let's just pick out an example. All right, can I do that?
Oh my God, I'm not going to stop you.
It's your show.
Yeah,
thank you.
We're just here.
Did you hear that? It's my fucking show. So let's talk about the brain, right? Like I said, methylation clocks are used to predict morbidity, mortality, and they're extrapolating based on algorithms to say, oh, well, this organ's going to get better, and this organ is also going to improve its aging based on algorithms looking specifically at when they can do the biopsies on these cells specific to an organ, or a lot of statistics to try to infer, right? Like, what is that? I mean, that's great for research, but that's not how physicians, we need to use our brains here. We need to know, hey, this is what I'm doing. I'm not doing this because some salesman comes in and tells me to use this test to show my patients that they're getting younger. What is that? That's all fucked up. That's not practicing medicine. That's not practicing improving cell efficiency and cell metabolic flexibility and cellular resilience, because we know GLP-1s, for instance, have a effect on, let's talk about the brain and how they tried to correlate in this paper. They talked about inflammation, the three big things that they were improving: inflammation, brain, and cardiac. And it's like, well, wait a second. I already know, what does a GLP-1 do in the brain? It improves survival of the cell, been proven through the PIK3 AKT mechanism pathway, that it improves resilience of all the glial cells and the neuron itself. And in fact,
and it also rewires in the brain too, to give you the ability to control things that you didn't have before.
Yeah, and you're talking about plasticity, you're talking about dendritic arborization, you're talking about improving synapses, like the network you're making better in the brain, which is happening. And that's because of mTOR. So mTOR is actually something that in the periphery, it's controlled, periphery meaning in the rest of the body, not the brain. It's a kind of a juxtaposition for mTOR, where mTOR is something that's dampened down and controlled because of AMPK that can inhibit mTOR. But mTOR is it's a growth factor. So mTOR in the brain, though, is turned on. And mTOR is improving connectivity. That's what happens in the brain. It's the same thing that happens in the beta cell of the pancreas. mTOR is turned on also. Had to bring in the beta cell.
Can't forget the beta.
So mTOR is important in proliferation and improving beta cell mass, which GLP-1s are showing this process. So I'm talking about papers that have shown these metabolic processes that we know have happened, and I'm giving you real mechanisms I'm working on. I'm not going to tell somebody I'm going to give you this test and I'm going to improve your longevity age and that's it. Like, that's bullshit.
Well, also with that test too, I feel like patients do get very fixated on it and they are really excited to take it again because they feel awesome, and then they get it and they're like 4 years older than what they were on their first test, then they just get defeated. And that one's a hard one to explain because it's like...
Well, what I'm trying to say is it has no correlation. You can't... It's a statistical reference for morbidity, mortality, meaning death and injury. And it's being extrapolated into longevity. That's great for research, but it's not plausible. You can't use it as a clinical test. I'm sorry, you can't. And that is something we could have great debates on, because I'm just touching touching the tip of this, where I've just gone through some mechanisms that have had multiple studies to validate and show, again, improving. What do I want to do? Do I want to use a test to prove that I've improved somebody's longevity, or do I want to show the clinical results and tests that show that I've improved efficiency, resilience, flexibility?
I'm going to go with option 2.
Right? I mean, so what am I, where you got me off, caught me off guard with this one, because I'm a little passionate about what's behind the scenes with these things. What are people... And again, this is peer-reviewed, guys. This is not peer-reviewed. This came from a BioRiv study. It hasn't even gotten into a journal yet, okay? So let's see where they go with this, because I'm sure there's a lot. If I was reviewing this, I would have all kinds of questions and to watch the wording of what you're trying to validate here.
Well, the discussion repeats, like you've said, well-established science related to GLP-1 RAs and their capacity to offset the inflammatory cycle that causes chronic disease. They frame these as biomarkers of geroscience. Am I saying that right? Geroscience?
Yeah.
You want to speak to this positioning of it?
That's okay. Take a AIDS patient. All right, let's make it simple. An AIDS patient that we know AIDS patients have increased visceral adiposity.
Fat around their organs.
Lipohypertrophy, yes. Which does what? We know visceral fat increases the chronic inflammatory state of the body. Known. Okay.
And isn't extra weight, like being overweight, you're also in an inflammatory state as well? Well,
we're assuming that when people are overweight, they have more visceral fat also. These are sometimes people that are skinny but have a lot of visceral fat
skinny fat.
Yeah, that you can't see.
And real quick, just to throw a definition in here in case anybody's not familiar, geroscience is a multidisciplinary field of study that focuses on the biological mechanisms of aging and its associated diseases, aims to understand how and why we age, as well as identify potential interventions that could slow or reverse the aging process and improve health span.
Well, we just talked about that, and this is where I just went through the mechanisms, and this is where I think geroscience, and no disrespect, great, brilliant minds there, They need to be paying attention to the things I just talked about, not a damn test. It's going to tell them that they're improving the longevity of an older person who doesn't give two shits about that, who wants to feel better, who wants to show me something that's improving. Don't give me some number, that you've just taken 3 years off of my life and like, well, what?
Is there standardization of those tests? Like, is there has a standard been developed that they base those numbers off
No,
of?
that's why there's different clocks. It's like one clock says 5 years, one clock says 2 years. Again, they're showing you this very large standard deviation changes that are big. And let's just talk about that. What would we like to do? We'd like to go into that brain glial cell, like the astrocyte, and take it, and then look at the methylation in that cell itself. But you can't do that. Now, how does that compare to the peripheral blood? No one has any idea. And the other thing that I think is understated here is there hasn't been anything to validate that by improving an epigenetic clock or a methylation clock is going to improve longevity. Sorry, hasn't been done. So you're making all of these assumptions. Why? I don't want to make assumptions when I'm taking care of somebody. I want validation. I want to tell somebody exactly what I'm doing. Hey, here are the steps. Here are the mechanisms we're working on. Here is where we're headed. Hello? I mean, so why are we selling ourselves short and buying into this bullshit and doing some of these testing methods that mean absolutely nothing? And that's my bias, okay? It's my bias. But from a research standpoint, I think it's great. It's validation that everything I've talked about in my book, they did a paper. If you want to make the claim on longevity, great. I think the claim is health span. You're improving health span, but I go through it on mechanisms, which everybody else should be doing the same thing, and pathways, mechanistic biology versus methylation clocks. Like, what the?
So what do you say? The pathways never change. The
Pathways
have
never
always been the
change. They
same.
never sell you out.
Well, and yeah, you're talking about the book here. Like the study points to the pleiotropic effects of GLP-1s, like semaglutide, supporting heart, liver, kidney. Like,
It makes a generalized statement. It's a great. For me, it's a great paper to put in here and say, look, all the things I said, look at this test. Do I use it? No.
Yeah.
Does it mean anything to me? No, because I already know the answer to that. It's like, yeah, of course I'm improving these methylation. Here's a
So would you consider it old or new news?
Old news.
What's that?
These pleiotropic effects since...
I feel like he's been talking about it.
We've been talking about it for over 15 years. I mean, well, here's something else. Let me just really quickly.
Oh God.
Okay.
Come on, you teed this up for me. Look, let's go through just a couple steps of where I can go right to telling you. Don't you want to know why instead of a? So if you're, let's take it from here. If I'm working on the efficiency of a cell, and when we're treating somebody, our treatment is focused on helping basically every cell in the body, right? And the key is, let's say we're going to focus in more on the mitochondria of the cell. We're going to improve its efficiency in how it handles certain substrates, glucose, fatty acids, proteins, to make that cell more adaptable to
Flexible.
And flexible to its environment. So let's say these fat cells in a AIDS patient they're not ideal fat cells. Their mitochondria are poor. They're producing immune cells to come in that are macrophages that are all producing these cytokines and chemokines and proteases that are creating this inflammatory state that is affecting other areas in the brain. And so if I'm going to work on improving that mitochondria, that is the key to doing what? Improving AMPK, to improving the context-specific in tissue, brain or beta cell or somewhere else, mTOR, to work on your
NAD production.
to work on your NFR2, which is your antioxidant system, right? I'm gonna produce more antioxidants. I'm gonna work on downregulating NFKB, which is the signaling of bad cytokines, chemokines, proteases. So let's say the mitochondria, just working on AMPK and then improving PGC1 alpha, mitochondrial biogenesis, improving oxidative phosphorylation, improving ATP, NAD. Let's assume I'm doing all those things and improving the SERT genes to improve the mitochondria, to do a better job. And then what I'm doing is I'm improving that mitochondria that has this effect on the Krebs cycle. That does what? The Krebs cycle, as long as that Krebs cycle is going well and not backing up, it's producing alpha-ketoglutarate, which has an effect on alpha-ketoglutarate deoxygenases, which are enzymes that control what? Demethylation of DNA and histones. TET 11, 12, 13, and Jumanji are these enzymes that are critical for controlling methylation. I just gave you the steps into how we improve methylation. Does that test do that? Did it look at that? No, it doesn't. So what I'm saying is, this is where I feel we lose our minds in listening to people that have no...
They don't take care of patients.
They don't take care of people. Yeah. They don't share your passion for getting someone better. They share a passion for making more money selling you a fucking test. I'm sorry. That's it. That's it. Their survival is based on that. Their survival isn't based on doing research with that. Their survival is to get a paper out, use that paper, go to doctors and go, hey, look at this. Did
the study contribute anything new or useful?
Yeah.
I mean, you did say at least it could back up some of the things in the book, right? That isn't necessarily new information. Okay. It just continues to validate.
So let me bring me back to earth here.
Yeah.
Do you need humbled?
I need to be humbled. It's an excellent paper to validate things, to validate for a greater group of healthcare providers that don't have this mechanistic thinking, and just to show them that, hey, the semaglutide, these GLP-1s, they have an influence on. That's what I was trying to say. They may have an influence on the immune system a little bit and on the brain and cardiac, but it doesn't mean any more than that. It's like, watch what you do with this aging. That's what all I tried to do in educating people there briefly. I mean, we should do a mastermind on this, on methylation and this testing. And this is a really good. This could be a fantastic mastermind. Actually,
this just feels like one of those situations where both can be true.
Yeah,
it gives you good information, but at what point does that information kind of stop to provide better patient care?
I think when they go through the peer review and there'll be some suggestions on, they got to be careful what they're saying and referencing. And these methylation clocks, these epigenetic clocks are getting a little bit, I think they're being misused. I think it's information. Mm-hmm. You can use it. I think it can be helpful, for...
So let's use the information.
Okay. So objectively, it can be something that a patient...
And this is today's performance protocol.
Yeah.
Oh, well, I don't use it. I don't use it. I think it's a great paper to put in context of what we've just discussed.
No, that's what I mean.
And no disrespect to all the guys who put in the hard work to make these tests, to correlate, but they're research-based. And they're trying to take something research-based and make it clinical. And I think that's a mistake.
Even though you don't need the validation because you know the pathways, you know how certain things affect the pathways, do you like when papers come out like this, though, that do support and validate everything you've been saying.
No, I should be smart and say yes, like, because it validates everything I've been saying. But I just know behind the scenes what's going to happen. Mm-hmm. That's what irritates me. But yeah, humble me again. You're absolutely correct. It validates to a degree that we're improving methylation to some degree. But can you again, it's like you're taking a peripheral blood cell and you're saying that you're going to tell, based on that peripheral blood cell, that immune cell that you're improving, are you truly improving like I said, let's say the astrocyte in the brain? No, you can't make that correlation. You just can't. But they do based on algorithms and comparing, and I just think it's too many extrapolations, and I don't practice like that.
So that's what we should make the performance protocol for today is like, what is the clinical takeaway here? How are you going to use a paper like this?
I'm not. I'm going to use it as just a teaching point now in
I told you so.
In helping healthcare providers want to know more about what we do.
Let me bring it more broad then. When people are reading, no, it's okay. No, this is good. This helps us continue to nail it down, right? Going through this exercise. So when people are reading papers like this, let's then make the performance protocol how you're supposed to interpret certain scientific evidence that comes out that's not yet peer reviewed. At what point do you put your own governor on? When are you pumping your own brakes here? How do you want people to be reading these papers?
I think it should take you to the step of asking why, what's happening. If there's some indication that it's improving the biological clock, well, what do I want to know?
How?
I want to know how. Well, can I make that determination by looking at methylation in a peripheral blood cell? No, I can't. But then how can I? Well, then I have to start looking at the mechanisms, the mechanistic biology of this peptide or whatever I'm looking at. What is it doing? Where is it affecting these molecular pathways to improve efficiency, resilience, flexibility? That's the key.
So when reading these papers, the takeaway, the performance
is
protocol.
Ask more questions.
Ask more questions. How? Why? Get into the mechanisms. Are they extrapolating or are they listening to the cell?
So
Ooh.
that's excellent. Actually, you've helped me think about so it's a great paper in leading you in the right direction.
Yeah.
Let's say, to start asking more questions, but don't sell yourself short and just accept that and sell your patient on that. I mean, know more. Mm-hmm. I'd hope you want to know more because if you, again, mechanistic biology is not anywhere close to making these statements about what an epigenetic clock or a methylation clock can do for you. And I think I made that best example of, something could be giving you years of, the test may say, I'm going to take 3 or 4 years off your life, but is that test telling me that I'm improving that endothelial cell in the heart to become less atherosclerotic? No, it's not telling me shit. It's not telling me anything about that. Well, I want to know those things. Yeah. I want to know everything. And so I got off track on this study.
You got off track?
That's the whole point of the podcast, is to let you go off track. So keep going.
I got off track because I got bent, because I know how these things are used to bend healthcare providers to use a expensive test that means nothing.
Well, hopefully you straightened them out.
But then again, if a patient wants to know it, then okay, I get it. I mean, I was there. Look, I was there before where I accepted and thought, well, okay, there's a place for this. But then and I saw it on the research side, and I saw it on, okay, yeah, it'll get me to, I just thought everybody was thinking the same way. Well, we'll ask more questions. But it stopped there. It was just like, hey, we'll use this test, we'll show this patient, and we're done. No, We're not done. We're just beginning.
I like that.
So
There's information, and then there's what you're going to do with that information. And what you're saying is, we get so focused on the first part that we lose, like, okay, now it's actually time to take action.
I want people I guess it's what I always talk about. I just want people to ask more questions, and to, just because it's a study and it says something doesn't mean you have to buy into all the bullshit of what the study's telling you. And these can be the best. Look what happened to women and hormones 30 years ago. You know, how that all fucked everybody up. But if you would have followed the mechanisms, followed the pathways, you would have never been there. And you would have been, and people like Uzi Rice were questioning those people back then. Like, what are you guys doing? Because he knew that. And he got blasted for it. And the guy was brilliant. And he said, I'm not accepting this. You guys go all fuck yourselves. I'm going to do this. And look how many people's lives he changed. Look at all the women he helped and was able to influence all of us. As I keep giving the guy incredible credit, you know, he helped me. Another guy in the forefront, you know, that helped me ask more questions. And of course, you know, it's all of these things that we find, you know, about these papers and how nothing's written in stone. And you may find out things that we say here and later on may not be true, but I don't think that's going to happen because we're following laws of molecular pathways.
You know how Chick-fil-A has that little cow? It says, eat more chicken.
Yeah.
We need one of like Doc that says, ask more questions. Could be a little figurine.
Well, if you have any questions, I'm going to do a very humble plug right now. His book, The Quantum Power of GLP-1 Peptides, dives into a lot of these mechanisms and really starts to flesh this out a lot more. And it's not Doc going off the rails, but I know we like both versions. So we have the structured version, and then we have the audio version. And I think this week's audio version, we should wrap it up and come to a close here.
Yeah, don't get me more confused. Well, listen, I forgot to start Matt and Maddie. I forgot that. I've been away for like a month, and I forgot Matt and Maddie.
We had to reacclimate you to the space.
That's okay. They cut to the camera angle where you were talking, and we both got our tears out.
Yeah.
So
all right.
Hidden.
I don't want you feeling bad.
We already did.
But I want Matt and Maddie, I want to say thank you for another episode on Redox Revolution. And I hope you can tell I'm excited to be back. And wow, what a way to get me going. I hope that was helpful, and I hope I didn't on my bully pulpit. I hope I didn't get a little too wacky.
That's why people come to you.
Yeah,
that's what they want to hear.
Most everyone's listening. So
no bullshit, right to it. After some rabbit holes, but
all right, we'll dive into more rabbit holes next week. Thank you.
Thank you.